And then we're going to get into the big topic of diarrhea and colitis, how they relate to each other clinically, pathologically. We'll talk about malabsorption phenomena and how to visualize it from a pathology and pathophysiology point of view. We're going to talk about the big topic of IBD, which is inflammatory bowel disease, technically Crohn's, colitis, and ulcerative colitis. We'll get into a few cute vascular problems, something that we're all going to have eventually if you don't have them already, divertics, and then get into the reasons for obstruction, which is a mechanical blockage of the bowel, and ileus, which is a physiologic blockage of the bowel. And then, of course, at the end, we always do our tumors. So how about if we get going? The question I have for this is, how do you turn 5 square feet into a tennis court? And the reason why that's an interesting question is if you know and you remember your geometry of how to measure the surface of a cylinder, if your small intestine is a 6-meter cylinder and it's just a couple inches in circumference, you can see it would be about 5 square feet if you did simple geometry. But if you look at the primary infolding, which if you remember are called the plicae, remember the submucosal invaginations, and then the villi, which are the secondary one, and then the microvilli, which is the surface of the actual epithelial cells, you now have a surface area that went from 5 square feet to a tennis court. So the surface area of absorption for your small bowel is as big as what, Serena Williams plays tennis on. It's really huge. And you can do the math if you want to. So it's a tremendous surface area. And like always, we have our 4 classic layers. And of course, with the small bowel, it's all serosa because it's entirely intraperitoneal, except for the most of the duodenum. And let's say that the large bowel is serosal about 50% because we got the cecum that's visible. We have the transverse colon, which is visible. We have the sigmoid, which is visible intraperitoneally. But most of the ascending and descending colon are actually retroperitoneal. So you don't see them when you go into surgery. Blood supply, if you remember, the superior mesenteric, the inferior mesenteric. The superior is the entire small bowel. You remember the duodenum had some branches from the celiac, the gastroduodenal, from the common hepatic. From the first branch. The superior mesenteric is the entire small bowel and a little portion of the large bowel, the colon, and extremely first portion of the ascending. And of course, the inferior mesenteric artery is basically the rest of the large bowel. It goes right colon, transverse colon, descending colon, all the way up to the superior rectal. Of course, there's a middle and inferior rectal, which does not come from that, but it comes from further down. Iliac branches. And remember, from the anatomy point of view, your superior mesenteric artery is not alone. It has branches with the celiac axis in the region of the pancreas, if you remember the pancreatoduodenal arteries. And it also has branches, collateral branches with the inferior mesenteric near the splenic flexure, the so-called marginal artery. So, here we go. Here's histology. Whoops, I'm getting a little bit ahead of myself, ain't I? Here you go. Here's your histology. And if you remember, with the small bowel, you have villi. The mucosa is a villus pattern. These little fingers poking up at you. If you've seen a really good endoscopy, you can see like little hairy things coming up at you. Those are the villi. However, in the colon, it's basically a flat mucosa, and you see these little pits. So here's the colonic pits, and then here's the colonic glands, the crypts, so-called, the crypts of Lieberkühn, if you remember. And then, of course, you have your muscularis mucosae and a lot of loose submucosa, vascular, maybe lymphoid under that. Then your two muscle layers, inner circular and outer longitudinal. And then, of course, you're either serosa or adventitia. And remember, with the small bowel, the outer longitudinal layer is continuous, but with the colon, the outer longitudinal layer is rather patchy because it is focused around the, oh my God, I got a senior moment here. What do you call those little muscular bands, Lois, that you have running linearly in the large bowel? The not tinea. Yeah, the tinea coli. That's it. The tinea coli in the large bowel are are groups of the longitudinal muscle bands. Here's a nicer histology picture. Here's your villi. The connective tissue of the mucosa is the lamina propria, a tiny little rim of muscularis mucosae. Remember, you do have smooth muscle in the mucosae as well. All of this loose vascular stuff, submucosa. And then, of course, in the small bowel, you could see that the inner layer is circular and the outer layer is longitudinal. So those smooth muscle cells are running parallel to the axis of the lumen of the small bowel. And here you got the large bowel now. You can see some lymphoid tissue, which is very common in both the submucosa as well as the mucosa. And sometimes it looks like there's a disruption in the muscularis mucosae because there is. This lymphoid tissue, or malt, if you remember, actually traverses the muscularis mucosae. And here you go, your fat and your blood vessels in the submucosa, your muscularis, circular, longitudinal, and then, depending on what part of the large bowel you're in, you're going to have either serosa or adventitia. Don't forget the enteroendocrine function. There's a whole wide variety. I really don't want to go in on it too much. You probably should remember, if you don't, you should review it, that there's a whole big family of hormones secreted from enteroendocrine cells that are deep within the mucosa, perhaps in the crypts or even in the small bowel. And of course, there's some exocrine sort of glands as well. If you remember, the Paneth cells, especially in the small bowel, have granules, but those granules are on the apical side of the nucleus, so they get secreted into the lumen where bacteria might be. Whereas the enteroendocrine are endocrine cells, so their vacuoles are secreted in the basal side of the cell, which goes right into the blood vessels. And here we are. I made a little list here. I don't want to go into them. Sometimes I can barely remember them myself, but you should know, especially with respect to the bowel, the general functions of serotonin, somatostatin, which we've mentioned yesterday, motilin. You would think that would be a motility hormone, wouldn't you? Cholecystokinin, very important for the gallbladder. Gastric inhibitory peptide. There's some neuropeptides, of which neurotensin is one of them. Vasoactive inhibitory peptide. So you would think that something like that would actually inhibit the action of the bowel. And of course, enteroglucagon. Just kind of remember what they do. Can't get away from the immune system. As you know, there's a tremendous amount of lymphoid cells, both primary and secondary follicles, studding the mucosa and submucosa. And you could generally refer to these as Peyer patches because a lot of people do. But if you actually look at the work of Dr. Peyer, the patches that he described were in a very specific place and did not really involve the entire bowel. But nevertheless, for all practical purposes, Peyer's patches or Peyer patches can be thought of as any mucosal or submucosal primary or secondary patch of lymphoid tissue that you see in the small and large bowel. Of course, they're rich in immunoglobulins, especially the secretory ones, because these guys are exposed to a lot of caca. Let me tell you, it's like a lot of horrible things that mucosa comes in contact with. So that's why you have a lot of lymphoid cells. And of course, most of the lymphocytes are B cells, simply because there's a lot of immunoglobulin that has to be made. Don't forget the neuromuscular functions. We know that the colon, the gut has its own brain. It's not only secondarily controlled by the vagus and the sympathetic for basically positive and negative functions respectively, but it has its own intrinsic brain. I think it's an evolutionary thing. So if you cut the vagus nerve and the sympathetic functions to the gut, you could still have a peristalsis simply because we have an independent collection of neurons called Meissner's and Auerbach plexuses. And if you want to think of Auerbach as those little ganglion cells you see always between the circular and longitudinal muscle layers, and of course the Meissner's, which is in the submucosa, that's the intrinsic independent brain of the gut. Okay, let's talk about diseases, but not in great detail. Remembering, of course, the embryologic history of the bowel and the fact that there's a lot of rotation that it has to do, and the fact that there could be parts of the lumen that are either extremely narrowed, which is called stenosis, or don't open up at all, which is called atresia. So there is a spectrum between atresia and stenosis. Atresia is the most spectacular form of stenosis because in atresia, there's no passageway at all. And stenosis is just very blacked. There are two herniations of the abdominal wall. They're similar, but they're technically different. One is called gastroschisis. The other one is called omphalocele. And they're related to the fact that parts of the bowel wall can herniate, abdominal contents. If you remember that there's a rotation in embryology, if that rotation is interfered with in any way, that you could have severe bowel problems on the basis of that. Last but not least, if you also remember from embryology, there was this thing called the Vitelline duct. Do you kind of remember that? Well, it could normally disappear or be a very, very tiny remnant in adult life or even childhood life. But sometimes it doesn't go away and there's a large pocket of bowel that pops out of it near the terminal ileum. And that's called the Meckel's diverticulum. And very, very often, a Meckel's diverticulum has ectopic gastric mucosa cells in it as well. So it could form a peptic ulcer, couldn't it? Last but not least, there's a disease in which the intrinsic brain of the colon, remember the Meissner's and Auerbach plexuses, don't develop or are absent. And that's called Hirschsprung's disease or aganglionic megacolon because the ganglia aren't there. So here we go. And remember, this is a gastroschisis. And most people confuse this with an omphalocele because it's near the umbilical cord, but this is a gastroschisis. A gastroschisis is a herniation of abdominal contents bowel in the region of the base of the umbilical cord. Omphalocele is also a herniation, but it's not necessarily following the exact base of the umbilical cord where you can see herniation of abdominal contents through the bowel wall. Here is a piece of bowel that looks rather normal here, and then all of a sudden it disappears. So either it's very stenotic or it's atretic, depending on whether it was narrowed or gone, respectively. Here's a classical place for a, what do you call it, Meckel's diverticulum. It's near the terminal ileum. And sometimes it could be almost as big as the diameter of the small bowel itself, but usually it's about as big as an appendix. It could be thought of as being a second appendix because it's in that general area. Here is a bowel that is tremendously dilated. And you see these in babies, and the reason why they're tremendously dilated is because there's not much peristalsis. And the reason why there's not much peristalsis is because there aren't any ganglion cells. There aren't any Meissner's and Auerbach's plexuses in the muscle and submucosa. and therefore this bowel is tremendously dilated. This is Hirschsprung's disease. And of course, the concepts behind malrotation are simply the fact that if you remember that small bowel and cecum has to rotate 270 degrees. If it doesn't make it all the way around or it gets confused in that long 270 degree rotation, you can have malrotation. And you could, as you guessed, this could wind up resulting in very severe problems. I wish I knew more about the treatment of it, but it's not that terribly uncommon. Okay, now let's talk about real non-congenital diseases. And if you remember, we generally progress from congenital to inflammatory to neoplastic and usually throw some degenerative in there. This is a big topic. It's the single biggest topic of today, except for maybe the neoplasm. And basically, it's a sum total of pretty much all of the common inflammations of the bowel, small and large bowel. That's why I call it enterocolitis. That's the disease. Those are the family of diseases. The main symptom is diarrhea. And even though you all think you know what diarrhea is because you've all had it, the diarrhea is defined as an increase in mass of stool or an increase in fluidity of stool or an increase in frequency of stool. All of those are generally part of the same process. So if your stools are more fluid or more frequent or more massive, that's all diarrhea. Rather than go into the massive differential diagnosis of diarrhea like a cookbook, we're going to take it from a point of view of pathophysiology. We're going to understand the differences between secretory, osmotic, exudative, malabsorption, and motility. And of course, we have to get into the infectious enterocolitis because, as we know, pathogens, numerous pathogens are responsible. We're going to touch briefly on the common ones, and then I'll mention probably briefly some of the more obscure, but things you should probably be aware of, like collagenous colitis, lymphocytic, colitis in AIDS patients, the fact that you can get colitis after a bone marrow transplant, just like we talked about with the stomach, a gastritis, drug-induced. As you might guess, aspirin's the top of the list, just like it was in the stomach, radiation, and the so-called solitary rectal ulcer, and maybe a little bit on typhlitis as well. And if you don't know what typhlitis it is, that means you didn't read your outlines today. A secretory diarrhea is usually virally caused, and it usually involves some kind of direct damage to the mucosal epithelium. It can also be caused by enterotoxins of bacteria. It could also be caused if there are tumors that are secreting GI hormones. You can have excessive diarrhea on the basis of excessive motility from these hormones. On the other hand, you can also have it from excess laxative as well. Now notice, in all of these cases, we are talking about either some kind of viral damage or enterotoxins. We're usually not talking about a direct invasiveness. So most of the secretory diarrheas are not hemorrhagic. They're just secretory. This is probably the single most common type. You know, you get your flu bug, your 2 or 3 day rotavirus stomach flu. This is what you're going to have, secretory diarrhea. It's not associated with a lot of damage to the mucosa itself. And here's basically your differential is viruses and bacterial toxins. Here's an osmotic diarrhea concept. An osmotic diarrhea is usually or almost never associated with much direct histopathology. Secretory, we said there probably a little bit, but osmotic, there's usually none. So basically, if you have a disaccharidase deficiency, you're not splitting up your lactose, and then that lactose is then being fermented by gut bacteria, you're building up a whole bunch of things besides gas. And on the basis of this, that sugar is acting as an osmotic attractant to prevent water from going into the bowel, and therefore you're having a diarrhea on the basis of an increased amount of solutes in the gastrointestinal system. Similarly, there's a lot of electrolytes in bowel preps and antacids, so forth, especially magnesium sulfate. So if you're going to get a diarrhea and you want the least amount of damage to your mucosa, osmotic diarrhea is the one to get because it's usually not seen as much histopathologic changes. Now, an exudative diarrhea is probably, in a way, often caused by an infectious pathogen, but now there's more damage. So it's not just secretory or fluid. Now you have exudate. You don't just have water now. You're having exudate. You're having maybe some fibrin. You're having perhaps blood. So, you know, a lot of the bloody diarrheas are exudative, and these are more associated with pathologic changes to the colon. And of course, there is a concept we'll mention a couple of times called typhlitis, and that's a relatively new term because it's becoming more popular with AIDS and when we know more about immunosuppressive disease. And typhlitis is an inflammation of the colon almost exclusively related to the cecum, usually in patients with leukopenia that are either suppressed for immune diseases or chemotherapy, in which they have a lot of inflammation in their cecum. And that's about all I'm going to say about typhlitis. Okay, let's talk about malabsorption diarrhea. Let's say you have a primary disease of the pancreas or of the small intestine in which you're malabsorbing. We're going to mention those diseases later. Well, if you're not absorbing fluid, which is the function of the bowel, then you're retaining fluid. So these are likely to be watery diarrheas as well. And you could look at it from a point of view of just increase in intraluminal water. You could look at it from a point of view as the mucosal cell surface or function. If this is interfered with, you're not absorbing. If you have lymphatic obstruction in the bowel, you cannot be absorbing properly. Or technically, if you have a reduced functioning bowel surface area, if a surgeon has to cut out half of your small bowel, you now have only half of a tennis court for absorption rather than an entire one. Last but not least, let's talk about the concepts of motility in diarrhea. And it's hard for most people to understand how both a decreased as well as an increased transit time can result in diarrhea. So I'm going to explain it. Well, first of all, decreased transit time means your bolus, your food, your poop is just going through too fast for any reason. So that by itself is diarrhea by definition, isn't it? Very, very common when there's reduced gut length or diseases which result in decreased transit time like hyperthyroid patients, diabetic patients. On the other hand, let's say that you have an increased transit time and that food is being in your bowel too long. Well, the longer your poop is inside the intestine, the more likely your normal flora is going to get really nasty and cause a bacterial kind of a picture. Remember, your normal flora is only normal because it's not sitting around in the bowel very long. If you have diverticula or blind loops or bacterial overgrowth, you now have an increased transit time, and those normal bacteria can start to get not normal. They can get pretty nasty. Okay, let's talk about the common infectious endocarditis now. We know classically viruses and bacteria. We also know that most worms, so when you rattle off the list of any type of parasitic worm, they're almost always in there. And generally, the parasites don't cause much of a pathologic change, but they can cause problems with absorption and a lot of symptoms as well. So let's talk about the single most common virus to infect the gut, the rotavirus. When you have the stomach flu, you probably have the rotavirus. There is also this family of calciviruses, of which Norwalk is one and Sapporo-like is one. And They are also pretty common, but they're not even half as common as the rotavirus. And of course, if you heard that there is a family of adenoviruses called enteric adenoviruses, you would expect that their primary area of pathogenicity would be the enteron or the gut as well. And I just added astroviruses because I want to be complete. It's not that common, but if you hear of an astrovirus, you know, you should think it's not infecting your astrocytes. It's more likely to be infecting your ass. Oops, I'm sorry, I shouldn't have said that. The bacteria that are common in infecting your gut, E. coli, always at the top of the list, okay? Salmonella, Shigella go hand in hand. Very often, it's a differential diagnosis as the Salmonella or Shigella. Campylobacter, very common. Yersinia, common. Vibrio, okay, which is cholera, isn't it? Cholera is infection of the gut with Vibrio organisms. Clostridium difficile, which is your antibody-induced enterocolitis. Clostridium perfringens, don't forget TB, as well as even your normal gut bacteria, if they stay there too long because they're in a blind loop or a diverticulum or not going anywhere, or decreased bowel motility from either anatomic or physiologic causes, or in other words, obstruction or ileus respectively, then you can get infection from your normal flora that way. And of course, if you remember that really, really long list of parasites, worms generally, of all the phylums of worms that infect the gut, you know, they generally don't do much direct tissue damage there, but they could cause a lot of symptoms. So what are the common viral ones? We've already said rotavirus, that's your typical one. It doesn't usually do much direct tissue damage. The crypts are usually spared. There's some damage to the superficial epithelium. And if you don't have to, I don't have to tell you this, because you know when you had stomach flu, it only lasted 3 or 4 days. And of course, it's from person to person, food or water, the typical way you get stomach flu. Bacteria. Bacteria can cause enterocolitis in 3 different ways. One of them is just to produce a toxin that accumulates in foods, and then you ingest those toxins. So, you know, staph food poisoning, botulinism from Clostridium, even Vibrio cholera. You know, these are all basically ingestion of toxins. It's not so much the ingestion of the things. Montezuma's Revenge, which they call traveler's diarrhea, usually is associated with E. coli, but I don't want to be too hardcore on that because the word traveler's diarrhea is so universally used. Technically, it means anytime you get diarrhea when you're traveling. Well, that could be a wide variety of things if you look at the big differential, but classically and statistically, E. coli is the most common. And that's because you're ingesting a bacteria now, which now produces toxins inside your colon. Remember, in the first one, you just ingested the toxins, theoretically. Now, the third and highest order of severity are your entero-invasive bacteria. They may not have much of a toxin effect from endotoxins, but they cause direct damage to the mucosa. And the big one there are your entero-invasive E. coli. You can have E. coli which produce only toxins, like theoretically Montezuma's Revenge, but you can also have strains of E. coli, you know, that are causing direct damage, including, you know, hemorrhage. And of course, Salmonella, Shigella, and the one we're going to talk about called Clostridium difficile in a little bit more detail. So what's an E. coli thing? Well, we all know it could produce a toxin, but it can also produce a direct invasive kind of a picture too, with an exudative kind of a diarrhea. And it's very, very, very common in infants. You know, E. coli enterocolitis is basically a very, very, very big concern in the infant nurseries. Salmonella and Shigella. We're not going to go into the whole history of each one, but these are very, very, very common. And I want to tell you a little bit of a pearl that I remembered, and it's really good, is that very often these organisms, because they behave similarly, are used together, and often clinically as well, you may have to decide whether an enterocolitis is a salmonella or a shigella. And the general rule is salmonella is not a hemorrhagic diarrhea, but shigella often is. Now, I know what you're thinking. You're thinking, well, didn't Dr. Minarsik 2 days ago sit down in that stupid chair and tell us that salmonella can cause a hemorrhagic gastritis? But you're saying now that he's in the lower part of your enteron, it usually doesn't cause a hemorrhagic colitis? And the answer is yeah. Shigella is much, much more likely to because the bug is a lot more invasive. Campylobacter, contaminated food, produces toxins, but it can also cause some degree of invasion as well. Campylobacter, very, very big bug as well in enterocolitis. Yersinia, does that sound familiar? I think it used to be called Pasteurella. Now it's called Yersinia. Well, that can produce a enterocolitis as well, and specifically Yersinia enterocolitica is the one that produces the enterocolitis. This is also something that can be from contaminated food and invasion. From a pathologist point of view, if you see a colitis in which there's a tremendous mucosal lymphoid reaction, tremendous hyperplasia of the Peyer's patches, you might be thinking, hey, is this a lymphoma causing the bowel disease? This is very, very commonly associated with Yersinia. So if you want to take something home, remember Yersinia is a big, big, big lymphoid reaction. Don't forget cholera. You know, these are the epidemics that occur in disasters where there's contaminated water, people eating fish, you know, oral fecal contamination, sewage contamination into fresh water, drinking water source, which could very well happen in catastrophes. That's why it occurs in epidemics. It's a watery diarrhea because the bug itself does not invade. It's if you remember, we said it's basically an enterotoxin, but don't let that fool you. You know, cholera, untreated, you know, has a significant mortality. Here's the one that you're going to be dealing with the most, folks. It's a bug called Clostridium difficile. That's the name of the bug. That's the name of the bacteria. It produces a toxin called Clostridium difficile toxin. You can actually go to any hospital right now, draw a patient's blood, and say, tell me if this blood has Clostridium difficile toxin in it. And the reason why you might want to do that is because your patient has a colitis and a diarrhea, and you got a GI consult, and the GI doc did his endoscopy, and he saw a lot of yellowish fibrinous exudate on the colon. And you're thinking, gee, these things almost can be peeled off like a little membrane, but it's not really a membrane. It's like a pseudomembrane. So the toxin of the organism Clostridium difficile, which you could measure in a lab test, is called pseudomembranous colitis. It's also called antibiotic-induced colitis because the etiology of this is that patients that have pseudomembranous colitis have usually been a little bit too long on wide-spectrum antibiotics, which wipes out their so-called normal gut flora and only leaves behind the ones that are not normal. In other words, Clostridium difficile, which is going to cause this horrible-looking colitis. And by the way, if you want to know what a pseudomembrane is composed of, and you guess that this is an exudative kind of a picture, you could think, well, is this mostly fibrin and perhaps neutrophils? Well, the answer is yes. A pseudomembrane is chiefly fibrin, mucus, and neutrophils. There's a syndrome called bacterial overgrowth syndrome as well, and we talked about this. And we said that normally your normal flora are not pathogenic because they don't have a really big transit time. But if they're trapped up in a blind loop of bowel or an area where there's no peristalsis because it's obstructed, or in a diverticulum, which basically is basically a pouch that just stays there forever, or a physiologic obstruction called paralysis, which is identical with the term ileus. Anytime there is significantly increased transit time, and that stool is winding up with a extremely larger amount of contact and the bacteria in that with the bowel, you can get a so-called bacterial overgrowth syndrome. I'm not going to go too much into the parasites under enterocolitis, but if you remember when we had that long discussion on infectious diseases, we talked about the common roundworms like Ascaris and Strongyloides and Enterobius and Trichuris. We talked about the hookworms or Necator and Ankylostoma. You should generally have the taxonomy in your mind. And don't forget the tapeworms as well. You know, the pork tapeworm, Taniosolium, the beef tapeworm, the fish tapeworm, which is Dilophyllobrothrium latum, the dwarf tapeworm. These are all tapeworms of tremendous worldwide importance. We just don't get them in the United States. So if you practice here, you're not likely to see much of it. But worldwide, they are of tremendous thing. Now, the general principle is, you know, with a couple of exceptions, the parasites that are worms do not generally produce much by way of histopathologic changes in the bowel or serious morbidity and mortality. And the reason for that is, you know, the number one principle about parasites, you know, both in reality as well as, you know, the kind of parasites that try to contact you on the internet, the successful parasite does not kill its host. So if these worms were causing a lot of morbidity and mortality, they also be killing themselves, wouldn't they? So that's why smart ones just generally keep a low profile and just suck those nutrients. On the other hand, some of the unicellular parasites like the amoeba and giardia, they can produce a significant amount of damage, and there's usually a lot of histopathologic change. And amoebiasis or amoebic dysentery caused by Entamoeba histolytica, which is the main one, can produce a significant amount of colon damage. And here it is. This is a colon in which you see there's a lot of inflammation in the mucosa. You don't know this is mucosa because it's zoomed in. And when you first look at it, you think, well, geez, those things look like a bunch of histiocytes. I don't know how you could call these things parasites. Well, they are, and they look exactly like histiocytes. They have kind of like a lot of foamy cytoplasm. The nucleus is more tiny, but this is a classic appearance for amoeba in the colon. Amoebic dysentery, genus and species name, Entamoeba histolytica. Here's probably the single most common one worldwide, Giardia lamblia, giardiasis. When you ingest the spores of this flagellate unicellular organism, they then develop, proliferate in the colon, cause a diarrhea. It's usually not severe, and it's usually not invasive. When you do a biopsy, you can see perhaps these are a lot of organisms, but they generally are not causing much by way of tissue damage, but they cause a lot of symptoms, can't they? And remember, I always mention when I talk about Giardia that it's one of the very, very few things when you look at it under the microscope, it's looking back at you because it looks like it's a little critter with two eyes that's telling you to focus in on your slide a little bit better. And it's flagellated as well. That is the classical appearance of Giardia lamblia. I think of all the things that you could memorize in terms of a quick microscopic recognition, Giardia lamblia is one of them. The only thing is he doesn't quite have a smiley face, but sometimes they do. So it's a cute little thing to look back at you on the microscope, but it's not a great thing to have. And this can be found even in ice. So I can remember once I was in Mexico and I said, hey, and I was with some people from a laboratory. I say, hey, let's get a snow cone. And somebody reminded me, hey, don't forget the Giardia spores can also live in ice. So this is just another reason, probably one of the most common reasons why you're not supposed to drink the water in a lot of third world countries. Okay, you know what? It's 9:47. I feel like we have been really covering the ground pretty quickly. I hope it hasn't been too quickly. It's a little bit faster than I usually go, but I think we're on a good track. And what I want to do is just kind of take a little bit of a break now for 10 minutes, and that way we're not going to feel rushed in the second half. Yes, Margaret has the little coffee icon. That means she's going to call us back in 10 minutes, right, Margaret?
Right. That'd be
But,
great.
but before you do,
Okay.
I need to know verbally or chattily if everybody has been hearing and seeing well today. I need a quick show of hands. Wow, 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 wow. Okay, good.
Great. I
Well,
have
because,
very high strength today for some reason. There's no snow, I guess.
okay, well, Margaret's Fios is on steroids today.
Okay.
Skip the slide, Jane. Thank you for reminding me, but who cares? Also, Isla, I'm going to overrule you again because I found a song we could play during break that is just too good to refuse. See you in 10 minutes, Margaret.
Okay.
Thank you so much. It's been a great pleasure playing for y'all. Thank you. Good night.
red wine, you make me feel so fine. You keep me rocking all of the time. Red wine, you make me feel so grand. I feel $1,000,000 when you're just in my hand. Red wine, you make me feel so sad. Anytime I see you go, it make me feel bad. Red wine, you make me feel so fine. Monkey packing is upon the sweet red wine. Red wine, you give me one heap to sing. One heap to sing, make me do my own thing. Red wine, you really know how to love. You're kind of loving like a blessing from above. Red wine, I love you right from the start. Right from the start, with all of my heart. Red wine in a 80s style. Red wine in a modern beat style. Yeah. Give me a little time, let me clear up my mind. Give me a little time, let me clear up my mind. Give me red wine, let me feel fine. Let me feel fine all of the time. Red wine, it make me feel so fine. Monkey back and loose upon the sweet headline. The line go, the monkey get choked. Fun bad gun, the pan and make a rubber mouth. Red wine, I'm gonna hold on to you, cause I know you love me. Red wine, I'm gonna love you till I die. Love you till I die, and that's no lie. Red wine can't get you on my mind. Wherever you may be, I'll surely find. I'll surely find. Make no fuss, just give me a little time, let me clear up my mind. Give me a little time, let me clear up my mind. Give me red wine, let me feel fine. Make me feel fine all of the time. Red wine, it make me feel so fine. Monkey packing loose upon the sweet devil. The lion growl, the monkey get choked. Bun bad gun, the pan and make it going out. Red wine, you really know how to love. You're kinda loving like a blessing from above. Red wine, I love you right from the start. Right from the start, with all of my heart. Red wine, you give me one heap of zing. One heap of zing, make me do my own thing. Red wine in a 80s style. Red wine in a modern beat style. Yeah. Red wine, you make me feel so fine. You keep me rocking all of the time. Red wine, you make me feel so grand. I feel $1,000,000 when you're just in my hand. Red wine, you make me feel so sad. Anytime I see you. She moves like she don't care. Smooth as silk, cool as air. Ooh, it makes you wanna cry. She doesn't know your name, and your heart
react?
Well, when Margaret says it's time, it's time.
It's time.
Okay, it reminds me of one of those little baseball expressions where they say, well, what's the definition of a ball or a strike? And does it have to be so many inches from the elbows or the knees or the plate? And somebody once said, a strike is what the umpire calls. So if we want to know if it's time, we don't have to discuss the nature of time. We just have to listen to Margaret.
Okay, that wins.
Okay, let's finish up a little bit. You know, we've dealt with the really, really, really big, long topics of diarrhea and enterocolitis, and I hope I arrange it in a relatively good, logical order. Some of the stuff we did not really go into in depth because I didn't think it was necessary, but the concepts of the various types of diarrhea and infections, and based on whether it's basically fluid or exudate or the amount of damage, and, you know, which conditions do it more and which conditions do it less. To me, from a pathologist point of view, that's the main area of understanding. Similarly, now, when we talk about malabsorption, you could think along it the same line. The purpose of the small bowel is to absorb nutrients and water. So if it doesn't, if it's diseased, then it malabsorbs. That's the general principle. And of course, if you look at the physiology of digestion and absorption and look at its various locations, both anatomically and physiologically, you can understand that if the stuff inside the lumen, if the lumen is a problem because maybe it's not getting enough pancreas or bile fluid or pancreatic enzymes, you could have malabsorption at the pre-small bowel level. Because the first area of contact of the nutrients and water is with the microvilli or brush border, you can have malabsorption at that level, histologically speaking, or if the cell itself, if the mucosal epithelial cell itself has a problem, even the lamina propria, because of, let's say, lymphatic dilatation, you can have a transepithelial concept of malabsorption. So these are basically the three areas. But remember, if you have a reduced mucosal area because of some kind of problem, maybe even post-surgery, or if you have lymphatic obstruction secondary to lymphoma involvement or infections, like some of the things we talked about, or previous surgical resection, these are all concepts of malabsorption. Let's talk about the mother of all primary malabsorption diseases, and that's celiac disease. And it has several different names, and they are all appropriate in their own way. Celiac disease is the official name, but it's also called sprue. And because some of the sprue occurs in epidemic tropical settings, it's called non-tropical sprue. And because we know that the etiology of it is sensitive to a protein in wheat called gluten. It's also called gluten-sensitive enteropathies. They're all names for the same thing. And the proof that's caused by gluten is that when the gluten or wheat products are withdrawn, the actual histopathologic changes actually go away. And we're going to talk about those histopathologic changes. But gluten in some people sensitizes T cells and produces this sort of autoimmune phenomenon. But there are other proteins, gliadin. There's also proteins in other grains like oat and barley and rye that cause a similar picture. And as long as we said picture, let's look at the picture. Here's the picture. If you remember, we told you that the mucosa of the small bowel here on the right, and remember, this is a small bowel disease. This is not a large bowel disease. We told you that the mucosa of the small bowel is villous. You see these little fingers popping up over here? These are the villi. Well, the histopathologic change with progressive inflammation in the mucosa due to sensitivity of the T cells by gluten is to not only have inflammatory changes in the mucosa, but to flatten and eventually make those villi disappear. So if a GI doctor gives you a small bowel biopsy and you think it's really from the large bowel, it could very well be that this is celiac disease because there is villus atrophy. So now we just learned a fifth or sixth term for the celiac disease from a pathologist point of view. It's progressive mucosal inflammation and villus atrophy. You see the word villus atrophy on the path report, they're probably talking about celiac disease. There's also a form of sprue or celiac disease in a way, which occurs often in epidemic forms, and it can be recovered with antibiotics, and it's not related to gluten, so it's a different disease. That's called tropical sprue. So tropical sprue is an infectious disease occurring in epidemics. It's not related to gluten sensitivity, but non-tropical sprue or classical sprue or celiac disease or villus atrophy or gluten-sensitive enteropathy, this is the one that's caused by sensitivity to gluten. Here is a pretty rare sort of primary small bowel malabsorption disease, but you have to know about it. It's called Whipple's disease. And Whipple's disease, like celiac disease, shows inflammatory changes in the small bowel mucosa. And in addition, not only are there inflammatory changes, but most of those cells in the lamina propria, they look very foamy. They look like foamy histiocytes. And they are foamy histiocytes. But the foam is not the usual things, tons and tons and tons of lysosomes. The foam are actually bacteria. And there's a specific bacteria that causes Whipple's disease, and it has a first name and it has a last name, and the last name is Whipplei. So if you ever see a bacteria that has the name Whipplei as the second name, you know that's the cause of Whipple's disease. It's a rod-shaped bacillus, and let's look at it. Here is a small bowel pattern in which there is no villus atrophy, but you can see there are tons of these foamy histiocytes in the lamina propria. And look, if you do a PAS stain on them, they all turn red. So that's the hallmark of this bacteria. I don't know if you have to remember this, but it's classical in pathology, is that these foamy histiocytes in the lamina propria are loaded with these bacteria, and these bacteria just happen to be strongly PAS positive. So if you do a PAS stain, which stains mucin, like you could see here in the goblet cells, see occasional goblet cells are mucin positive. You then go from a white foamy pattern to bright red. And if you do electron microscope, you see this little broad bacteria, and their last name is Whipplei, and their first name is Tropharema. So it's better to remember it by the last name rather than the first name, because Tropharema Whipplei causes Whipple's disease. And no, Whipple's disease is not gotten from squeezing the Charmin. Let's talk about disaccharidase deficiencies. That's also malabsorption, isn't it? And the reason why it's malabsorption is because the person doesn't have the enzyme lactase and other disaccaridases, but lactase by far is the most common. And in disaccharidase deficiency, you don't have the enzyme to split lactase, and therefore it can't be absorbed, because you remember only the monosaccharides can be absorbed. If you remember your GI physiology, so you have a disaccharide, lactose, and it can't be split because of lactase. It's not absorbed because of osmotic diarrhea, and therefore it acts as a nice little sugar for a bunch of normal gut flora, which then ferment it. And one of the fermentation products is gas, and now you know why lactase deficient people pass a lot of gas. And by the way, this is like an extremely, extremely common disease, and it's by genetics too. I forget exactly, but certain races, certain countries, you know, Asians, Scandinavians, blacks, whites, like some of these subgroups have a tremendous incidence of disaccharidase deficiency, you know, 50, 60, 70%. And some of them are relatively free of it. But let's just say if you drink a glass of milk at night and you have gas all night, I think that's a really, really good diagnostic test for disaccharidase deficiency or lactase specifically. Let's talk about A-beta lipoproteinemia. We mentioned this when we talked about genetic diseases, and we mentioned this when we talked about blood vessel diseases. It's an autosomal recessive disease. It's relatively rare. But what does it do? Well, patients with A-beta lipoproteinemias don't have beta lipoproteins because they can't make chylomicrons. Remember, the chylomicrons are made from fatty acids and glycerides? Well, if you can't make them, you can't absorb the fat. And if you can't absorb the fat, you're going to have a lot of fat in your diarrhea. And that's called steatorrhea. So the concept, I think, is very, very logical and clear. So we have just, I think, pretty much touched on the main facets of malabsorption. And now let's get into a really, really, really big, big, big field of GI medicine called inflammatory bowel disease. You're going to have a lot of patients with IBD, inflammatory bowel disease. You may know people in your family and friends that have inflammatory bowel disease as well. Now, in the older days, the word IBD was not really used that much. It was generally always divided into Crohn's disease and ulcerative colitis. Crohn's and ulcer, they're basically two different diseases, but because they have such remarkable etiologic and pathologic and clinical and treatment similarities, they now tend to be lumped again into this family of primary IBD. And of course, IBD stands for idiopathic because still nobody knows exactly what causes them. Okay? They have common features in that they're both idiopathic. They have common features as that they're both in more developed countries like the US. They're less common in third world countries. They have common features in that they produce patterns of colonic inflammation, sometimes similar, sometimes a little bit different. They have a similar type of therapy too. So even though they're technically can have slight differences in pathology, the treatment for both of them can be quite similar with immunosuppressives and certain diets, and they both have a cancer risk. Now, let me just tell you right now, because we're looking at all these common features, but I'm going to show you a lot of little differences between the two. But I want to show you right now, when you're looking at this one PowerPoint slide, the main pathologic point of differentiation. Look, I said they both have colonic inflammation, right? Could it be acute with neutrophils? Yeah. Could it be chronic with lymphocytes and macrophages? Yeah. But if you see granulomas, it's Crohn's disease. It's not ulcerative colitis. So granulomas is probably the only factor that's found in one that's not, otherwise there's a lot of overlap. And look, here are some of the overlapping differences now. And you should probably know this, and that's why I made it yellow. Crohn's disease involves not only the large bowel, but very, very often the small bowel. We said it can even involve the stomach and the esophagus and the mouth. It's a total GI disease. Crohn's disease has granulomas. Ulcerative doesn't. Crohn's disease involves the full thickness of the GI wall, mucosa, submucosa, muscularis, and therefore it can form fistulas because of weakening in the muscularis, and you can actually have fissures deep within the wall, whereas ulcerative is generally limited to the mucosa. The classical place for Crohn's disease is the terminal ileum, which is the small bowel, and for that reason, it was called originally regional ileitis because it seemed to crop up most often in that regional part of the ileum called the terminal ileum. Crohn's disease also has skip areas. You could have an area of normal and abnormal. Ulcerative is pretty generally diffuse. Crohn's disease, you don't see little pus pockets in the mucosa as often as you do with ulcerative. So a crypt abscess for ulcerative is a lot more common than in Crohn's, but you almost never see granulomas in ulcerative. And of course, because this is primarily more of a mucosal inflammation in ulcerative, you're more likely to get bogginess and polypoid features of the mucosa called pseudopolyps. Whereas in Crohn's disease, you don't get pseudopolyps. In Crohn's disease, you're more likely to get malabsorption. Why? Because it's more likely to involve the small bowel. That's why. Let's take a look at this grossly. If you're looking at a colon microscopically and you see this beautiful little granuloma composed of histiocytes, and maybe you could even start to imagine some beginning of giant cells. You see a well-formed little granuloma in an inflamed bowel, you call it granulomatous colitis. Another name for granulomatous colitis is Crohn's disease. If, on the other hand, you're looking with the endoscopist, your GI doc friend, through his little endoscope, the patient's under, they got some Versade, he's letting you take a peek, or you're looking at the television, and it looks like there's all these little polyps. That's probably more likely to be ulcerative because it's primarily a mucosal disorder, so there's a lot more edema and bogginess of the mucosa, whereas the inflammation in Crohn's is full thickness. So here's your question. Now that you're an expert, is this ulceratives or Crohn's? Well, if you look closely, you might think, well, gee, this is kind of looking like a pseudopolyp, so maybe it's ulcerative. But look deeper. Look at this is a fissure. This is involving the muscularis. Ulcerative never does that. So this is Crohn's disease because Crohn's disease is a transmural inflammation, all four layers. Ulcerative disease is more primarily mucosal. Okay, so much for inflammatory bowel disease. Let's talk about a few cute little vascular diseases. Of course, one vascular disease is lack of blood flow. Another one is this very, very, very common thing called angiodysplasia, which is a horrible misnomer because it's not dysplasia at all. And of course, the single most common vascular disease of the planet, hemorrhoids. So here's the principle for ischemia and infarction of the bowel. You already know from the chapter on hemodynamics and blood vessel disease that you could have ischemia or infarction on the basis of an arterial thrombus or an arterial embolism or a venous thrombosis even. Or if the patient's in shock, you have not only total body hypoperfusion, but bowel hyperperfusion as well. Or secondarily, if there was something infiltrating a blood vessel or mechanically obstructing it. Those are all the conceptual reasons for bowel ischemia and infarction. But the first manifestation of a bowel infarct or disease of ischemia to the bowel would be mucosal changes. The mucosa is the first thing to go. And then if it's really, really, really progressive, the whole wall goes. But it's always the mucosa first. And this is the concept right here. In a mucosal infarction or an early infarction, you primarily have degeneration and loss of the mucosa. And it'll look very hemorrhagic. But if it gets more progressive or severe or sustained, then the whole wall thins out and it looks purple like this. So here's the principle. If it's an early or small or mucosal infarction, you open it up and there's hemorrhage in the mucosa, but the wall feels good. If it's transmural infarction, the wall is paper thin and the whole thing looks purple. And that's what the pathology is. Another type of vascular problem, very, very, very common, Radiologists love to make this diagnosis because they do angiograms and they see twisting and turning of these little blood vessels in the colon, and they call this angiodysplasia. And it's not called dysplasia because it's going to progress into a, blood vessel sarcoma. It's called dysplasia because it's twisting and turning and not behaving nicely. So, unfortunately, we should have never let those radiologists invent pathology words. But anyway, if you look at angiodysplasia from the mucosal aspect, you're seeing a lot of prominent blood vessels through the mucosa into the lamina propria and mostly submucosa. If you look at radiologically, you got a lot more twisting and turning of vessels. And if you look at it pathologically, take a look. Here's the mucosa. Here's the muscularis. Here's the submucosa. Here is a fold of submucosa. If it was really big, you could call it a plica, couldn't you? And in the submucosa, you just have a lot of prominent blood vessels. It is by no means premalignant. And neither are these, because here's your classical hemorrhoids. I think we looked at this in one of our lab cases. And if you remember, you have both internal and external hemorrhoidal veins in your colon. And a good general rule is if the dilated veins are covered by squamous epithelium, you're probably in the external hemorrhoids because that's anal mucosa. Whereas if your dilated blood vessels are covered by a thin columnar colonic type of epithelium, it's more likely to be internal. There's a lot of exceptions to that rule, but pathologists like to think very, very similarly. And that's what hemorrhoids look like. Nothing but big, horrible, dilated vessels. Sometimes it could be thrombosed. This one could very well look like it's in the process of thrombosing, but it's not quite as red as the other ones. This one looks like it might be forming a little bit of fibrin as well. That's what hemorrhoids are. And, of course, anything that increases intra-abdominal pressure, anything that might cause you to grunt or Valsalva maneuver, including chronic lung disease, including urinary obstruction, anything that causes chronically increased intra-abdominal pressure will complicate hemorrhoids. Okay, let's talk about a disease which virtually everybody has. And the reason why I say that is, like, I've probably done 8 trillion autopsies. And if you do an autopsy in an older person and you do a good autopsy and you carefully examine the bowel, which you really don't want to do because, that's the stinky part. You let the diener or the lab assistant or the path assistant do that. But you can see divertics in almost every older patient. It's very, very strongly related to old age. And it would be more common in the parts of the bowel of the large bowel, primarily. It's not a small bowel disease. It's a colon, large bowel disease. It's more common where the stool is harder. So it's more common on the left side of the colon. You can get it anywhere, but generally it's more common on the left side. So the further you go down distally towards the anus and the large bowel, the more likely you are to get divertics. As you would guess, if you have an increase in luminal pressure, age, the fact that it's more common where the stool is harder rather than soft, or a person that has a low fiber diet and therefore a decreased transit time and more impaction of stools and weakening of the wall, these are all factors for diverticulosis. And if those diverticuli then become inflamed secondarily, just like an appendix. You have an appendix, but when it becomes inflamed, it's called appendicitis. You can have diverticulosis. They're not going to give you any problems, but they become inflamed, then it's diverticulitis. And clinically, diverticulosis can very, very much mimic appendicitis, except remember, we said they're more likely to be on the left side, the sigmoid region in the left colon, than they are on the right. But very, very often, clinically, A patient with, older patient with abdominal pain, fever, tenderness, the basic diagnosis is diverticulosis versus cancer because older people just generally don't get appendicitis that much. So what can the divertics do? Well, they can become impacted with feces because they're bulging out of the wall now, aren't they? They can become inflamed if there's lack of blood flow to that area or attacked by pathogens. They very easily can become inflamed. If they do, it's almost identical to appendicitis, except it's probably going to be more likely on the other side. They can perforate. Those divertics can perforate. You can release feces into the abdominal cavity, causing a significant local or even diffuse. They can even bleed. And I want to tell you something. Normally, you don't think of diverticuli as just bleeding, but let me tell you, it's it's not uncommon to have a older person die of massive GI hemorrhage. You do the autopsy, and all you see are a bunch of bleeding diverticuli. So remember, just bleeding itself is a complication. They can obstruct because once you have a diverticulum that's inflamed, you then have thickening of the wall. You could then have paralysis of the wall. You could then just have edema in that wall to cause a mechanical kind of obstruction as well. Diverticuli are really, really, really common. Folks, I guarantee if you live to be as old as me or even older, heaven forbid, you're going to probably have divertics. The one thing that they don't do is turn into cancer. However, from a surgeon's point of view, they can look like cancer on radiology, on a GI series. They can even look like cancer after the surgeon resects that portion of bowel. It's very, very, very common that they take out a portion of bowel, large bowel that was obstructed, and then they send that piece of bowel to pathology and they say, is this diverticulitis or is this cancer? And it's only after you do a careful gross examination and you open up that obstructive segment and you wash off the mucosa and you see those little diverticulae perhaps poking out, that you could say. It's usually, you don't need a frozen section for this. Usually a good gross exam is good enough. How do they form? Well, if you remember, when you have your mesenteric vessels out here branching, the colic artery branches perforate from the serosa into the submucosa. Well, when you see all those big submucosal vessels, if you follow them through the muscularis, that's a theoretical weak spot. So most diverticuli occur in that area where you could see relatively large vessels traveling from the submucosa through the muscularis into the adventitia or serosa. That's your potential weak spot, and that's where the diverticuli appear. Here's what they look like grossly. If you do a good gross picture, you can see you have your normal little infolding of mucosa, but look, some of those little buggers are going all the way out. That's a classical diverticulum. So is that, and possibly so is that, because you're not always very lucky to see the actual connection between the diverticulum and the mucosa. More likely than not, it's kind of been fibrosed over and all you see are these little pockets in the fat. And of course, here you are microscopically, and you could see a diverticulum that has poked through. It's primarily mucosa, and it's primarily connective tissue. You don't normally get muscularis in the wall of a diverticulum. And for that reason, most of the diverticuli of the bowel are what you call a pseudo-diverticulum. Remember, we told you that to have a true diverticulum, you needed all four layers, like a Zenker's diverticulum, but a pseudo-diverticulum is less than four. So most diverticuli are actually just evaginations of mucosa through the muscle surrounded by the connective tissue of the serosa or adventitia. That's what a diverticulosis segment of bowel might look like. But really, in all honesty, could there be a cancer there as well? If this is the only thing you're looking at, hell yes, that could be a cancer. But if you open it up, you know, the surgeon gives it to you. These are nicely clamped off. You cut it open and you can see there is no mucosal tumor. And then you cut through the connective tissue and maybe you'll be lucky enough to see little balls of feces impacted in the adventitia and pericolonic fat. The very first autopsy I went to as a medical student, the pathologist was popping these little feces balls out of the fat. And I said to myself, do I really want to be a pathologist? Here's a diverticulitis microscopically. Basically, you may find some remnants of mucosa, like perhaps here, but more likely, you're just going to see a lot of irregular inflammation and thickening in the pericolonic connective tissues. If you're really lucky, you'll get a nice section through that little ball of feces as well. Okay, let's get into an even simpler, logicaler, a more nice topic called obstruction. And this doesn't take a degree in rocket science. Think of your anatomy and your physiology and your knowledge of pathology and ask yourself, how can bowels be mechanically obstructed? Well, statistically, the most common reason is previous surgery. Because when you do a surgery on a patient, you introduce that serosa to gloves, to instruments. Maybe it's already been inflamed. So post-surgical adhesions or fibrous thickenings of the outside of the bowel is the most common cause for anatomic obstruction. Patient has a lot of abdominal surgery. They're likely to have adhesions. They can be clinically painful. If you have impaction with feces, older people, very, very common, that can obstruct. You got a big ball of hard poop there. It's not letting anything else through. Herniations of bowel, from all the reasons. If you herniate a significant part of the bowel, you can obstruct it that way. You can have a valvulus or a twisting of the bowel on its long axis. Or you can have an intussusception of the bowel, which is like an inversion of a glove. We'll show you what intussusception looks like. Tumors, as you could guess, either intrinsic or extrinsic, mucosal or serosal, or primary or metastatic. These are all possible reasons for bowel obstruction. You can have obstruction secondary to a lot of inflammation because there's a lot of fibrosis going on, or obstruction like Crohn's disease. You can get strictures and atresias. And remember, strictures are very, very common in Crohn's disease. Or you could have a atresia secondary to severe strictures. Atresia, meaning there's no lumen left. You can have stones. You can have fecaliths. And as you know, a fecalith, which is an impacted, perhaps calcified portion of feces, is very, very closely related to appendicitis, isn't it? You could have foreign bodies, or you could have congenital problems where there's residual bands. We could have meconium that's obstructed. You could have an imperforate anus, which is not an uncommon condition in babies where they just don't have the opening to the anus. Well, think about it. You know that's going to obstruct things. So here's an example of a herniation, an abdominal hernia obstructing a bowel. Here's an adhesion in which you have stickiness of the serosa to each other. An intussusception is like a telescoping of a bowel, and a valvulus is a simple twisting of a loop, okay? Know the difference between intussusception, which is like a telescoping into itself, and a valvulus, which is a simple twisting of a loop from the other dimension. The obstructions that we just talked about were anatomic obstructions, and that's the way it's easy to think of anatomy. But don't forget, you can also have a physiologic obstruction as well. And a physiologic obstruction due to some mechanism that causes decreased motility that is primarily physiologic is called an ileus. So a mechanical obstruction to a bowel is an obstruction, and a physiologic obstruction is called ileus. The most overwhelming cause of an ileus is post-surgical, and that's why if you've had surgery or you hang out with the surgeons or you do follow-up on your patients, they look for bowel sounds. They get out their stethoscopes and they're listening for bowel sounds the day after surgery. And if they don't hear them pretty soon, they're going to get worried that there's an ileus. So basically, that's the main reason why that surgeon is whipping out his stethoscope, and he doesn't care about the chest. He wants to listen for bowel sounds. You want to get that bowel going again after surgery because normal surgery interrupts the motility of the bowel, sometimes for a day or so. Of course, if the bowel's infarcted, that's a physiologic cause. Or any of the so-called neural innervations of the bowel, motility diseases like Hirschsprung's disease. You have obstruction, physiologic obstruction or lack of peristalsis there simply because there are no ganglion cells to encourage peristalsis. Okay, well, let's see. Now we're in our last field here. We're going to talk about tumors. They always save tumors to the end. And unfortunately, pathologists love to talk about tumors the most. And it's always very tempting to go into a lot of different tumor classifications to show you how damn smart I am. But I have to really be practical and realize from a medical student's point of view, I think you want the basic classifications, the basic grading, the basic staging, the basic appearances. And you don't need a massive differential diagnosis, which pathologists love to pontificate about. So let's talk about tumors. Benign tumors, malignant tumors, epithelial tumors, which you would guess would be mostly adenocarcinomas if they're malignant, right? Or polyps or adenomas if they're benign. You could have tumors of the lymphoid tissue, usually of the mucosa or submucosa. So all your basic classification is here. But the thing I want you to remember the most about tumors is to go back to your histology again. And I do this over and over and over again, and I'll do it for every damn chapter. I don't want you to sit there and think, oh, I got to memorize the types of tumors of the pancreas or the bowel or the gut. Think of the histology. If you remember the normal cells that populate bowel, like smooth muscle, like glandular epithelium, like blood vessels, like fat, like fibrous tissue, like lymphoid tissue, then basically you just told me the entire classification for tumors of the bowel, haven't you? That's the way to do it, folks. The most common benign type of tumor is called a polyp. But I want to be a little more specific here because many polyps are not what you call true clonal neoplastic proliferations. Anything that causes a bulging or a blebbing of the mucosa, even if it's a submucosal lipoma, even if it's localized edema. Remember, we saw that in the inflammatory bowel diseases with ulcerative colitis. There's basically two kinds of polyps. After you take away all those weird situations, GI doctor looks into the colon. He sees a little polyp, a little bulging thing into the mucosa. It looks rather singular, like a berry. You could pick it off. And basically, the pathologist is then going to tell him whether that polyp is hyperplastic or adenomatous. And as you might guess, a hyperplastic polyp is probably not a true neoplasm because it has a mixture of cells. There's still goblet cells and absorptive cells. So it's even though they call it a tumor or hyperplastic, it's really not a true neoplasm. And because it's not a true neoplasm, it is not associated with malignancy. Never, ever, ever. A hyperplastic polyp never develops into cancer. On the other hand, if you have a true clonal proliferation of mucosal glands, which can look very much the same as a hyperplastic polyp, generally maybe a little bit bigger, that's an adenomatous polyp. Adenomatous polyps do have a statistical association with malignancy. Does that mean they all developed into cancers? No. Does that mean that they could appear sometimes dysplastic? Yes. And folks, like the thing that's kind of like when I talk about capitalistic pig medicine, I'm telling you that we all know, and you should know, that most adenomatous polyps do not develop into cancer. But let's say that you were a GI doctor and there was a statistical possibility. You're probably going to scare the hell out of your patient and say, well, these are linked to cancer, so you better come back here every 3 months and pay me every 3 months, money, money, money. So I'm sorry if I got off on that rant, but let's get back to regular medicine here. Polyps can look like they have a nice little stalk, and that's called pedunculated or the peduncle. And usually the fibrous tissue of the stalk is submucosal connective tissue, or they could appear like they're quite sessile, like they don't have a stalk. And they could just appear like a little bush that doesn't have a tree trunk. They can have both a tubular pattern where they look like they are little round circles histologically, little balls, or they can have a villus pattern in which they have a papillary configuration and they look like they're growing like little finger-like projections. So here's a concept as well. Here is a general hyperplasia of the mucosa, and it develops into a hyperplastic polyp. It has all of the regular mixture of cells that the mucosa does, except it's thickened, and that's what they call the hyperplastic polyp. It's generally limited to the mucosa. Now, an adenomatous polyp, if it has a stalk, most likely it's going to suck up that stalk from the submucosa if it has a pedunculated tubular pattern, or it could grow like a bush. And if it's growing like a bush with no stalk, that's frequently going to have a villus pattern. Now, the reason why it's important to differentiate these little tubules, which I'm going to show you in a minute, from these little villi, and here you got a picture of one. And this is the same picture we had at the title to our chapter, because it's probably the most common type of specimen that pathologists get from a GI doctor. Here is a mucosa of a colon. Here's normal mucosa. Here's submucosa. The submucosa is rising up to form these little glands. And if you look at these glands, they all look round, basically round, 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 round. They're not cancer. They're not invasive. It's a benign adenomatous neoplasm. But look, here's a polyp now, a sessile growing thing that has a villus pattern. You see? These are all like little fingers. Here you have linear papillary projections. And up here you have these circular areas. The reason why that's important to differentiate is I told you that the tubular adenomas or adenomatous polyps have a statistical relationship to cancer. Let me tell you something. The villus adenomas have a very, very, very high statistical relationship to cancer. And a lot of the old surgeons will tell you, and the literature probably supports it, that with time, almost every villus adenoma will eventually develop into a cancer. And that's probably correct. So here's what you take home. If the glands are growing in little circles and tubules, it's a statistical risk. If the glands have a finger-like pattern of growth, it's more than a risk. It's eventually going to be cancer. Okay, and of course, you remember, going back to our basic concepts again, if the cells themselves are darker, more irregular, have more mitotic counts, that's one way of differentiating benign or malignant glandular neoplasms. If you have nests of glands invading the stalk, so in other words, if you're looking at this under a microscope and you're wondering, gee, is this benign or malignant? But then you see a little group of cells here well within the stalk, you don't have to pontificate anymore or wonder. You know it's malignant because these cells should not be invading the stalk. So that's another and probably single most important point of differentiation. When you get a polyp that has a stalk, make sure there's no glands inside the stalk. Otherwise, it's cancer. Here's the hyperplastic polyp. You can see it looks like normal mucosa. There's goblet cells. There's absorptive cells. It has kind of a serrated appearance. They often talk about the serration pattern because it's in and out like little secondary villi. Here's a classical tubular adenoma. It basically looks round or maybe a little bit oval. But here's a villus. Look at this. These are basically little finger-like trees, aren't they? Remember, this villus adenoma has a lot higher statistical association with cancer than your regular old adenomatous, which you see here. Okay, you know that neoplasms can be familial. There's familial polyposis. We're not going to go into the genetics of that because it's horrendous. Most of the familial neoplasms produce polyps, which are not associated with cancer, but some of them do. So the classical familial polyposis is what they call hamartomatous. They're overgrowths. They're not really neoplasms. They're not monoclonal, but some of them can develop into cancer. The most important genetic disease, however, is what they call HNPCC, hereditary non-polyposis colon rectal cancer, which means this is a situation in which many people in the family get colon cancer, but they don't get it from previously existing polyps because it's non-polypoid. So HNPCC also has a complex genetics. And really, I'm not going to bother you with that. And, you know, Samir, I'm very sorry. You know, I know you're a good genetics guy and all that stuff. But to tell you the truth, I've never met a genetics doctor yet that knew how to speak, you know, to earthlings. I mean, I know a lot of genetics people from the university, and they could tell you, you know, GCAGG, and they know all the genes in that. But for somehow, they've never really been able to speak regular English. So I'm sorry if I did that little slam on you. If you find a genetics guy that knows how to speak to earthlings, let me know because I want to talk to him. Nevertheless, I want to at least mention briefly that there are several genes which are basically growth regulatory genes, like all cancers, that are involved with cancer genetics of the colon. You know, if you have a loss of a APC gene, highly associated with colon cancer. If you have a mutation of your KRAS, not only colon, but other cancers, you know, there are certain transcription genes called SMADs. If you have a loss of them, you're at risk for cancer. Of course, the big thing, not only with colon, but probably most human neoplasms, is a mutation in the P53 gene, which puts you at risk. And last but not least, of course, if you have telomerase activated, like we talked about in the chapter on neoplasms in general, if you have telomerase breaking up, you know, telomerase is your telomeres basically are limited in number. So most cell divisions are limited because of your telomeres. But if you have telomerase breaking up your telomeres, you then have unlimited cell divisions. So all these are genetic factors in cancer of the colon, as well as many other areas. And I don't want to go into it anymore, partly because it's so complex. I'm not sure if I understand it that well myself. I'll be very honest with you. What are other real cancer risk factors? Well, family history, age. You know, it's rare to have colon cancer under 50. You know, people that have low fiber diets or high meat diets or long transit times or have a diet of refined carbs, sugars, and these are all people that statistically are more likely to develop colon cancer. And it's very easy to understand why. And I'll tell you the reason. The reason is that if there is something in your diet that is either a primary or a secondary cause of cancer, remember the initiators and the promoters, if you have a carcinogen in your diet, the longer that carcinogen is in contact with your colon, the greater your risk will be. That's why people with long transit times, perhaps because of low fiber diets, A high fiber diet is something that has a high transit time. So if you have a low fiber diet, long transit time, you're going to have more exposure to the carcinogen. And that's the reason. Cancers can develop from adenomatous polyps, or they could develop all by themselves without polyps. And as you know, like we've showed you every other time in every other system, you start out with a normal appearing gland, a normal appearing cell. It then develops all of the usual features of dysplasia, hyperchromasia, pleomorphism, mitoses, perhaps back-to-back appearance where there's no longer connective tissue separating glands. The general principle is once it gets through the mucosa, once it breaches the muscularis mucosa, it is then potentially metastasizable. And on the basis of that, that's how the grading goes. And we're going to look into the grading. But first, we're going to show you some nice little pictures. Remember with the stomach, we said that it could be exophytic or ulcerative or diffusely invasive, like a lineatus plastica. Well, here, these are just regular adjectives now. They're not precise classifications. They are gross growth pattern adjective to describe to many of the growth patterns. They could be polypoid. In other words, they look like these little polypoid mucosal exophytic structures. They can cause constriction and be annular, and that's the one that might give the appearance of diverticulitis. Or they could just be diffuse, like the lineatus plastica. So basically, we're talking basically about the same kind of thing here with stomach, only we're using different adjectives, aren't we? Now, the one thing that we will say similar to the stomach, because I'm going to show you these pictures all over again, is that here's a papillary growth pattern because the adenocarcinoma has a little stalk of fibrous connective tissue and it's lined by little epithelium. That's the definition of a papilla. Here is a neoplasm, and you may wonder if you only looked at this part here, you may go to a million pathologists and you say, is this benign or malignant? And half of them will say benign and the other half will be malignant. But then if you back off and you show them the big picture and you look at these little buggers here, and I did a little inset of this, if you could see glands that look kind of borderline, but they're completely within smooth muscle, they're no longer borderline, are they? They are invasive because borderline glands don't invade smooth muscle. Only cancer invades, remember? So there's a papillary pattern. There's your tubular pattern. It looks exactly like a tubular or adenomatous polyp, except it's malignant. There's a mucinous pattern. And as you guessed, that white stuff, you'd say, gee, there's a lot of white yucky stuff here. Maybe that's mucin. So you do your mucicarmin stain, and sure enough, the tumor cells are positive. They're red. So that's a mucinous pattern. There's a signet ring pattern. If this looks like exactly like the slides I showed on stomach, it's because it is. Because these are all basically histologic appearances of various types of adenocarcinomas. And the less they look like glands, like the signet ring doesn't look like gland at all. It looks like individual cells with little mucus pushing their nucleus off to the side. The less they look like glands, the less differentiated they are, and therefore the more invasive and the worse the prognosis will be. Here's an adenosquamous, just like we showed in the stomach. Let's talk about grading. And this is a very logical to me, and I hope it's logical to you. You know, they had what they used to call a Duke's classification for bowel, and that has kind of fallen aside. A lot of old surgeons still talk about Duke's classification. But TNM is basically what everybody is pushing. And if you have an adenocarcinoma, but it's limited to the mucosa, it has not breached that muscularis, you call that adenocarcinoma in situ, or TIS. Once it breaches into the submucosa and it goes into an area where there's blood vessels, is potentially metastasizable. It's called T1. If it goes up to the muscularis propria, which is the thick muscle, but it doesn't penetrate through it, it's T2. If it goes into the muscularis propria, it's T3. If it goes beyond that or into contiguous organs, then it's T4. NX is you don't know if it's metastatic or not. N0 means you looked at all the lymph nodes and they're negative. N1 means it's only in 1 to 3 lymph nodes. N2 means it's in more than 4. MX means you don't know if it's metastasized. That's what the X stands for, unknown. If you say M0, you did your careful anatomic and clinical staging and there's no metastases. But if you see holes in the liver or the lungs, you could say that's M1 for distant metastases. This is a logical scheme. I don't know if I'd recommend learning it rote, but that's generally a very, very, TNM for the colon is the best example of TNM. It gets a little more complicated for the breast, but TNM for the colon is your classical TNM classification. Well, as you might guess, because you have lymphoid tissue in your mucosa and submucosa, you can get lymphomas. And of course, they would be maltomas, wouldn't they? Because this is mucosal-associated lymphoid tissue, or malt. You can get benign or malignant tumors of the smooth muscle. You can get benign or malignant tumors of the fat that's surrounding the colon or in the submucosa. And you can also get carcinoid tumors, which are really neuroendocrine tumors. And remember, they can secrete serotonin and they can result in diarrhea because serotonin has a bowel stimulatory effect. You remember that? You can also get carcinomas of the anal canal. And because if you remember, the anus is surrounded by squamous mucosa rather than columnar, like the rectum, they're probably more likely to be squamous cell carcinomas. And unfortunately, the anal carcinomas are generally have a lower prognosis than your regular old run-of-the-mill colon carcinoma. Mostly because of the potential spread in that area is a lot worse. And as you also might guess, because it's a squamous neoplasm, it's probably more likely linked to that virus that causes squamous neoplasms everywhere else, especially the cervix. So there's a strong link between squamous cell carcinomas of the anus and HPV. We're done with large bowel. I really would like to finish the last few slides. Margaret, you're the boss. I'll leave it up to you. Should I finish or you want to go home?
Yeah, let's finish. We have a few little bit, more to go.
Okay. Because it's just a small thing. We've covered esophagus, stomach, small bowel, large bowel. We did lab on a lot of the upper stuff. Now let's talk about the appendix. Remember, that was the first question on your thing. We showed you a normal appendix. Take a look. Here's a normal appendix. What's the thickest layer of the appendix? It's not the muscularis like the rest of the bowel. It's the submucosal lymphoid tissue. There's loaded with lymphoid tissue in the mucosa and submucosa. Now, if you remember, the appendix is at the junction where the 3 tinea meet. Classically, it's very variable in location. The surgeon fears this the most because if it's retrocecal or something, he's going to have a harder time taking it out on laparoscopy. And unlike the rest of the GI thing, the thickest layer is the submucosal lymphoid. The 4 diseases of appendix are acute appendicitis. You all know that because you did that. Everybody did the first slide in lab. You can have a collection of regular old mucus in that appendix called a mucocele. Most mucoceles of the body are in the appendix. I don't know why. You can have a benign tumor, a benign glandular tumor of the appendix, which is also rich in mucus, called mucus cystadenoma, or you could generally have a malignant tumor of the appendix, relatively rare, called a mucus cystadenoma. So all of the tumors of the appendix, whether they're just cysts or benign or malignant clonal proliferations, they all have mucus in them. Acute appendicitis is caused are generally related to fecaliths, impacted feces. You can't always find a fecalith, but the general principle is because you got a big hard stone in there, it's not getting good blood supply, so it becomes inflamed. And if it's very, very early, it may only involve the mucosa and submucosa. And that's usually not clinically significant. Usually you don't feel that. So in other words, to diagnose bona fide acute appendicitis, you need neutrophils in the muscularis. And that was the first question on your lab test. And, you know, the surgeons live in fear of taking out a lot of normal appendices because sometimes these patients come in with right lower quadrant pain and they want to pretend like they got the right diagnosis. So they want the pathologist to tell them that appendix is inflamed. But if you don't see neutrophils in the muscularis, you can't call it acute appendicitis. Technically, the appendicitis can rupture, or you can have localized or peritonitis. And if a patient is going to die from lack of surgery for acute appendicitis, it'll probably be because of peritonitis. I'm not going to tell you a bunch of appendix stories with surgeons. Here's what it looks like. Question is, the fat or the mesoappendix, the omentum of the appendix is often indurated because of the inflammation. You know that white stuff is fibrin, right? And you know that if you cut through this, you'll have neutrophils in the muscularis. If there are only neutrophils in the serosa, maybe this is not a primary appendicitis
You
at all,
have
but
an
maybe
incoming
it's part
call
of the
from Grant
peritonitis.
Whitman.
If there are only neutrophils in the lumen, maybe those neutrophils are coming from higher up. So that's why you need to see them in the muscle layer. And there you go. There's your smooth muscle layer. There's a normal appendix on bottom. All you see are nuclei of smooth muscle cells. On the top, you see nuclei of smooth muscle cells, but they're infiltrated by neutrophils. Okay, we already said that mucocele appendix is very, very common. They could be very, very, very large, but they're usually not. And if you have a benign, true clonal adenoma or a malignant one, they're also loaded with mucus as well. If that mucocele ruptures and it's big enough, it can spread little mucus crap all over the peritoneum, and that's why it's called pseudomyxoma peritoneum, because it's not a true tumor. It's just abundant mucin in the peritoneal cavity secondary to a ruptured mucocele. Nevertheless, if it was a mucus carcinoma and it ruptured, it would also send mucus all over the peritoneum. But in this case, there'd be tumor cells as well, wouldn't there? Malignant tumor cells. Here's a ruptured mucocele. It's pretty big. Looks like a big bag of mucin all over the place, perhaps obstructing or disrupting the normal anatomy and physiology of the bowel in that area. Here is a normal adenoma that you might see in a colon, part of an adenomatous polyp. Here is a carcinoma of the appendix, which is always loaded with mucin. And if you did a mucin stain on this, you know it'd be positive. You know that red mucicarmin stain would be inside the cells and all over the place. And remember, these can rupture too, and they could spread a mucus all over the abdomen. But in this case, when you look at the mucus, you're going to see tumor cells there. Okay, last but not least, we've covered about every part of the bowel you could conceive of, except for the peritoneum now. So let's say a few words about the peritoneum. The peritoneum, like the pleura, like the pericardium, is lined by mesothelial cells, not only along the surfaces of the organ or the visceral aspect, but also the abdominal wall, which is the parietal aspect. So technically, if you had an appendicitis that ruptured, you're going to be seeding that peritoneum, at first visceral, but eventually perhaps parietal, with inflammatory cells. If you have rupture of a viscus, like a colon or an ulcer, that would be a setting for acute peritonitis. If you rupture your gallbladder, these are all easy concepts. You're basically rupturing tubular intra-abdominal organs, and you're releasing the harsh contents into the cavity, and that acts as an irritant. Ruptured diverticulitis, salpingitis. In this case, you actually have pus flowing out of the open end of the tube. You're not rupturing anything, but you could rupture something as well. So basically, these are your causes of peritonitis. I hope they're all logical. And in that case, you would see that these mesothelial cells, if you did um, a, a, an analysis of the fluid, you would see a lot of these little mesothelial cells, but you'd probably see a lot of inflammatory cells too. If you saw tumor cells, then you know it was probably a malignant process that was perhaps rupturing one of these organs, wouldn't it? What are the common bugs that are cultured when you have a peritonitis due to rupture of these luminal structures? E. coli, top of the list. You know, Enterococcus, the anaerobe, that's always very, very common, as well as strep and staph, which, as I told you originally, is basically everywhere. Every type of infection always includes strep and staph. What is the outcome of peritonitis clinically? Well, it could completely resolve, or it could result in a walled-off abscess where you have a localized pocket of pus and secondary fibrosis later going on. You can also have adhesions, you know, so peritonitis by itself is much more likely to cause some type of bowel adhesion rather than just completely resolve. Last but not least, I think, we got to tell you about one more condition called sclerosing retroperitonitis. If you remember from your anatomy and your cadaver, we had this big retroperitoneum. It encased the adrenals, the pancreas, the kidneys, the ureters. And there is a disease called sclerosing retroperitonitis. It's probably autoimmune, mostly because we haven't found anything specific, external pathogen that might cause it. And basically it progresses to general retroperitoneal fibrosis. And think about that. If you got ureters lying and being encased in that retroperitoneum, and all of a sudden you got a fibrotic process there, you're going to externally close off those ureters, aren't you? So as you might guess, the single most feared complication of sclerosing retroperitonitis is hydronephrosis, and then secondarily leading to renal failure. Last but not least, we've already said this for lung, because the peritoneum is lined by mesothelial cells. The only possible type of primary neoplasm you could have a peritoneum is a mesothelioma. Like in the lung, they could appear as solitary benign nodules, or they, if in the malignant fashion, they could cause a diffuse constriction. And don't ever think that mesotheliomas are limited to the lung. They're limited to any area where there's mesothelium, both parietal as well as visceral. Last but not least, if you have a metastatic carcinoma, you know, to the peritoneum, that's going to result in adhesions. If it was a mucinous carcinoma, you might think it was a pseudomyxoma peritoneum. But the difference is, if you send that fluid to your pathologist, he's going to tell you there's tumor cells there as well. And guess what? We're only 6 minutes overdue. I sort of apologize. I really don't want to go overtime